Hey, it's Rob Fitzgerald. Thanks for tuning back in. Have a quick discussion about therapeutic drug monitoring. Some people call it therapeutic drug management. And we're going to talk specifically about the anticonvulsants because the anticonvulsants are one of our common drug classes that is subject to therapeutic drug monitoring. So before you order a drug level on a patient, you need to think about a couple of things. What is it? How is it going to be helpful to you? One, you can identify noncompliance. So some drugs are very effective. People think they're better, and they just stop taking them. And if you're trying to manage them pharmacologically, one way to figure that out is to do TDM. Is the drug present? You can also do dose adjustments. Things like, if a patient have renal disease and their renal disease is getting worse, you can monitor their drug concentrations and it might correlate to altered pharmacokinetics. We can look at drug-drug interactions. Drug metabolism either can be, you can stimulate metabolism or you can inhibit metabolism. And by doing TDM, you can identify that. So what kind of therapeutic information are you going to get? And is there a therapeutic range? If there is no accepted therapeutic range, it doesn't make very good sense to do TDM because, what does the concentration mean? Are there clinical effects that are correlating to your observations? And if so, TDM might be useful. Finally, specificity of the assay, and is the drug metabolized to active metabolites, and does the assay pick up the active metabolites? Really important is the time between when the dose was given and when the sample was collected. So we're going to talk about trough versus peaks. And trough is very simple. It's right before the next dose. That's a true trough. You draw the sample right before the next dose. Peak samples depends on the route of administration and the drug. And so those are specific to each drug. But a trough is simple and generally is what is the draw of choice for most TDM. And does the clinical value of the measurement justify its cost? So jumping into the anticonvulsants, Dilantin or PHENYTOIN is subject to therapeutic drug monitoring primarily because it has saturated pharmacokinetics at therapeutic doses. So linear pharmacokinetics mean you double the dose, you double the concentration. Nonlinear or saturated pharmacokinetics, if you double the dose, you might get an 8-fold increase in concentration. So it's really hard to do dose adjustments, and by looking at concentrations in circulation, we can at least get an empirical understanding of where we are and what did the dose adjustment do to the drug concentration. It works as through sodium channels, inactivating sodium channels to decrease transmission of neuronal signals. It's an anti-epileptic, and we do have a reasonably good therapeutic range, 10 to 20 milligrams per liter. It's highly protein bound, and so if you add another drug that displaces it from its binding, you can get toxicity without even changing the concentration of the total drug. So in that case, the free drug concentration goes up, but not the total drug concentration. Has an apparent half-life of 8 to 60 hours. And so what does that mean? That means that essentially we don't know what the half-life is because it has saturated pharmacokinetics. And it varies widely depending on how saturated you are. Typically we do troughs for therapeutic and random or peaks for toxicity. Dose adjustment is primarily empirical. We make a dose adjustment and we do TDM to see are they in that 10 to 20 range and do they have any signs or symptoms of toxicity. So nystagmus or drowsiness, ataxia, sort of CNS kind of depression kind of signals. Interestingly enough, if you give enough phenytoin, it starts to mimic the disease you're trying to treat. So it causes tremors and seizures at high enough doses. Simply, we treat it by stopping the drug and letting it metabolize off. It's a difficult drug to to manage, and so we see lots of issues with Dilantin. One of its adverse effects is gingival hyperplasia, and so long-term effects would be gingival hyperplasia, maybe 40 to 50% of the patients that take this drug. Valproic acid is another anticonvulsant known as Depakote. It inhibits GABA transaminase, and so GABA is one of our major inhibitory neurotransmitters. And so if we inhibit the metabolism, GABA sticks around longer, and we decrease transmission of neuronal signals, and that's why it's an anticonvulsant. Pretty well absorbed in a couple of hours. Half-life changes, and so with age and also with hepatic function, and so that's why we do TDM. Fairly wide therapeutic range, 50 to 150 milligrams per liter as a trough. It does cause toxic hepatic encephalopathy, so that's why we monitor it to make sure that we don't get that. Phenobarb, another anticonvulsant, still commonly used, works through GABA as well. It's working at the GABA receptor, unlike valproic acid, which is working on an enzyme that metabolizes GABA. So it's a direct GABA agonist. It causes the GABA receptor to open, chloride ions come in, and we hyperpolarize, and so we decrease transmission of the signal. Generally well absorbed in about 4 hours. Very long half-life, so if you're doing dose adjustments, we talk about waiting 4 hours, so we have to wait, days to weeks to come to a new steady state. 10 to 40 is its reference range. It's a CNS depressant, so its toxicity are going to be, ataxia, slurred speech, people acting drunk but not smelling drunk. So a CNS depression toxicity. PRIMIDONE is both a prodrug as well as an active drug itself. It gets metabolized to PHENOBARBITAL, and so this is a case where you need to measure both the parent compound as well as its metabolite. Well absorbed, half-life of about 10 hours, therapeutic range of 5 to 12, and you also need to be measuring its phenobarb. Again, like phenobarbital, it's a central nervous system depressant, and we're going to see similar signs and symptoms. Carbamazepine is erratically absorbed. It's highly protein bound. Those are sort of two triggers for doing TDM. Its half-life changes with therapy, so it induces its own metabolism. It has a fairly narrow therapeutic range, so 4 to 12 milligrams per liter as a trough. In kids, they form a specific metabolite, this carbamazepine 1011 epoxide, that has activity and should be measured, or at least think about being measured if you're dosing children. So blurred vision, nystagmus, and ataxia would be signs of toxicity. It also causes hematological depression, so bone marrow depression, and typically these patients are monitored with CBCs to make sure that you're not getting that kind of toxicity. ETHOSUXIMIDE, ZARONTIN, half-life of about 33 hours, reasonably well-defined therapeutic range. GI distress, lethargy, and dizziness would be toxicity. And that's a quick overview of, an introduction to TDM and some of the more commonly measured anticonvulsants. Thanks for tuning in.